Uh, Welcome to Madras Medical Mission. We have with me Dr. Ashish Chopra, Dr. Rahul, sisters Freddie and his group of technical staff, and Ravi with us. And we hope to show you a case. So please go ahead, Ashish, and tell us the history.
So, good morning and welcome to the transmission from. So, let me discuss about the case. It's a 69 years old female presented with unstable angina, and for which angiogram was done, which showed a single vessel disease involving the mid LAD, and associated comorbidities is diabetes and systemic hypertension.
Okay.
Routine echocardiogram showed normal LV function and a baseline creatinine being zero point 0.9 milligrams per deciliter, and the syntax score is 10. So hence we decided to go ahead with the PTCA to LAD with imaging guidance, and imaging was tool is today being IVUS. So this is the angiogram with the epicaudal view and as well as a PA cranial view, which shows the mid LAD calcified diseased uh, with that good TIMI3 flow, and different views which suspected that some disease in the diagnosed as well. RCA is dominant with a very mild plaquing noted in the proximal RCA, and here we had to go ahead with the PDCA to the LAD.
Okay, so good morning. And from the aim of this case is to show imaging guided PCI in a bifurcation LAD diagonal. You can see in the first view today that you can see there is a LAD lesion which is extending from the diagonal origin to the mid LAD, which is about 80%. Patient came with angina. This distal LAD looks like about 275 millimeters in size. There is a diagonal origin disease, and we hope to wire the diagonal and protect the diagonal during the procedure. The plan is to first pre-dilate the LAD, which seems to be calcific. Can you play the run again, please? So you can see that before the dye gets injected, there is a calcification both in the PA cranial and the LAO caudal. Can you play back the LAO caudal view? And you can see again here, you can see right from the proximal LAD, there is calcification which extends through the diagonal and septal to the mid LAD. So as we were waiting for the case, we just got in and sort of trying to wire the diagonal. I think we are in the diagonal. Small check, please. And what we'll next do is possibly, after we wire the diagonal, we'll get in a wire into the LAD. So the aim of this case is to show a simple bifurcation with calcification where how we deal with it. And we use quite a lot of imaging in our hospital. Almost 30 to 40% of our patients get imaged with IVUS and OCT. So what we'll do next is to wire into the LAD to show the IVUS. And as you can see that lesion is pretty tight. So we expect the IVUS not to cross very easily. So what we'll do is after we pre-dilate with the 2.5 non-compliant balloon, possibly we'll get the IVUS through. So there are two wires. We have the cyan blue in the diagonal, and we're now going to get a wire into the LAD. This is a BMW wire. So let me ask Ashish, maybe how would you plan the case, Ashish, if you are doing the case?
So of course, protecting the diagonal is going
Small
to
check.
be a key because it's a huge branch. So as we all know that provisional single stent strategy is evidently much better. So we will try to keep it simple, crossing the LAD, pre-dilate and assess the IVUS, and then take a call on the diagonal how it deals with.
PA
If the diagonal pinches, or probably just try to do a simple bifurcation ballooning, And if the flow is good, I would just like to leave it alone and do much to the LED alone.
We'll check.
So this is the 014 wire which is crossing into the LED. We had some little resistance probably because of the tight stenosis. So
Okay, so we've got two wires in, uh, and we first will dilate the LAD and then possibly do an IVUS for you. So 2.5 non-compliant. What size balloon is this? The 2.515 balloon. So this is a non-compliant balloon. So you can see the calcification here very, very clearly in the artery, and we expect on the IVUS to see the severity of the calcium to decide what sort of debulking strategy we're going to do. Small check. Okay, let's
so
go
the
up there, please.
balloon is crossed and we are just going to pre-dilate with the 2.515 non-compliant balloon. As you
So you
can
can
notice, the balloon has a small slip,
go up slowly.
probably of significant lesion. So I hope
Deflate,
they
please.
all can appreciate the calcium,
So the
which was.
lesion has come up at about 12 atmospheres. Small check, please. Go up again, please. So the length is 12,
15.
15 millimeter. Okay. So it's a 15 millimeter balloon. So yeah, deflate, please. So let me get the IVUS catheter down. This is a Boston Scientific Polaris machine with a Boston Scientific catheter. This is a high definition
Okay.
catheter and HD IVUS catheter. Yeah, that's fine. You can give a little bit of GTN, yes, maybe. Yeah.
I think they're doing.
So before the IVUS, as my technician said, Freddie said we should give some NTG so that the vessel is not undersized in the whole bargain of doing the stenting. So here you can see that the vessel is coming up nicely. We'll take a shot now. So the vessel looks much bigger now.
So
It seems to be a 3+ vessel
as
now.
earlier thought of 275 at the distal, but it looks beyond that. Probably the imaging will give us a better picture in this scenario.
So as much as possible, unless it's a very big vessel, we do a provisional strategy in our hospital. We use only 2 stent strategies in case we have a large diagonal circumflex with a osteal disease which is extending into the origin beyond 10 millimeters. In this patient, I expect that that diagonal is about 2 millimeter vessel. So we would not possibly go ahead and do too many things unless we pinch it during the procedure. So that's the high definition IVUS of Boston coming through. And so can we now show the IVUS pictures, please?
So
So
IVUS switches crossed into the LED beyond the mid LED, and this is the live demonstration of the imaging where you can see the distal vessel. So shall we record? So I've started recording. The pullback has started as we are able to cross lesion, and we are coming up at the mid LED, there's one diagonal which is septal. Now you can notice some sort of calcified vessel along with from fibrotic stenosis. This is the diagonal, the lower diagonal. And over here, if you can notice, it's more of a probably 180-degree arc of calcium, and beyond which is good. Some sort of calcium between 1 to 2 o'clock.
That's okay.
Over
So
here is the
that's the left main,
left
and
main.
here we are out of the left main and
All
the
right.
ostium. So I think we'll take some pictures and measurements and then
All right.
discuss this case with you.
So
So the important is after the recent data with intravascular imaging, it is getting more and more clearer that image-guided PCI is the most important way of reducing
the
bad
septal, the
outcomes, both
lesional
in
clear
terms of stent thrombosis
is a normal.
and in terms of late restenosis. So intravascular imaging is a must, especially when you see complex lesions of B2 or C characteristics, so that we get good outcomes. So we're making some measurements here. I hope you can see that there.
So this is beyond the septal portion we have crossed because this is a normal segment. So the area which is around 8, but the reference range is around 3 millimeter.
So
So
the
coming
luminal area is about 3, maybe 3 to 5 would be the EL to EL. We can't see the EL very clearly. And then we come into the lesion now.
coming up at the lesion junction.
So obviously we've pre-dilated this lesion and you can see from say 9 o'clock to 3 o'clock, a lot of plaque there. Here it seems to be mildly calcified only.
So over here the area is around 2.7. Coming to the calcified portion where it was much narrow.
So that's the tightest part maybe, where you can see almost 180-degree calcium. And it extends from 9 to 3 on the other side.
So
Luminal
this is
area
the
is
area where
low
our
despite the balloon dilatation.
all right.
You see here the vessel gets bigger, and you can see that at the diagonal, yeah, that's the left main. Come back to the diagonal. Yeah, so there's the disease, and you know,
At the proximal LAD also about 180 degrees of calcium is noted. So area is
see,
around 6.8.
the, the area is about 3. The diameter is about 3. So let's now measure the length. So it's about 3 distal, 3 plus proximal. And can we measure from just before the diagonal, first diagonal, where we have wired the lesion, to the end of the lesion?
Since it is a little calcium, I'm going little beyond.
Yeah, so that should be good. Maybe there, that's possibly the good part of the vessel.
Which is about 32 millimeter
Okay, so this is just from the beyond the
beyond
septal to the
proximal to the
first
diagonal.
proximal part of the LAD, which has disease proximal to the diagonal. So it's about 32 millimeter. I think it's a bit bigger than 3 here. And can we measure that area there? Yeah, it's about
It's
3.5.
3.5. So
So I
probably
think
we
if,
go with the 3 mm stent size, about 32 millimeter, and post dilate with 3.5.
okay,
The only question arises with a 180 degree of calcium, should we use any uh,
yeah. So I will tend to use a cutting balloon
balloon?
here.
All right.
So we will use a 3O Wolverine. Can we open that to nicely prepare the lesion? Then do an IVUS once again to see how much fracture we've got of the calcium, and then possibly then decide about the stenting strategy. So we're going to open the 3O Wolverine and do the cutting here. So this lesion characteristics is a long lesion starting from approximately the diagonal to the septal. The lesion has a fibrocalcific characteristic. It's 180 degrees at the tightest part, the calcium, and we may argue that we may
Inner
not need a
diagonal will go.
Wolverine and we may just do
Hmm?
plain stenting directly without a cutting balloon. But in our hospital, we try to as much create a good lumen before we stent
Okay.
so that we get the best. So here we have the Wolverine trio, and we will use that now. Okay,
Just circle.
keep the IVUS ready after this, please.
Yes, sir.
One check, please. Go up, please.
Got it.
So this is a 3O, 3O10 Wolverine. Yeah, it's come up reasonably well. Deflate, please. Go up again, please. Deflate, please. Inflate, please. Deflate, please. So you can see there's a bit of a waste there. It's a small check, please. That's where the real calcium is. Okay, so you're going to go up a little higher pressure there. Yes, please. 6, 8, 10.
Can you do?
It's a bit better than before.
So the
It's not
dog
an
bone
inferior
effect is
part.
much better.
Please deflate and keep the IVUS ready.
Ulnar septal, inward septal, inward septal.
Yes, please. So what you're going to now see with the 3O Wolverine, what we have done on the IVUS imaging.
Then a normal under then septal in the under. So again, we are going to recross
We're
our
going to read
imaging
this
catheter
IVUS again. We have now just got
after
beyond the lesion.
use.
Okay,
All right, so let me go live.
it's all right. ठीक है? Huh? Yeah, we can put it.
So I started the pullback as over here coming from the distal LAD where we can notice small septals which are all totally normal segments. So coming at the pullback, this is the septal, all the fibrotic disease which was over here, and this is another septal which is arising at the 6 o'clock position. Over here, if you can notice the diagonal as well as the wire which is marked over here, and this is the LAD which was still calcified, and you can notice some dissection plane at the calcium beyond.
Okay, so
So
what
this
this
is the
now
left
clearly
wing.
sees is a larger lumen, very clearly. Can we see some cuts if you
Yes.
can,
I'll just
Ashish?
show you
Yeah.
once it stops. All right. So coming from the distal segment, this is your septal. This is where the disease portion was, and over here is all about the fibrofatty plaque which was noted, and over here the calcium starts. As we come beyond at the delivery junction, you can notice over here some cuts of the calcium.
That's a very good cut, Ashish. Yeah.
Yeah. So over here you can notice the cuts noted at between 4 o'clock to 5 o'clock position, and even at the 6 o'clock to 7 o'clock you can notice some sort of uh, cuts noted from the cutting balloon which was used. So as we come beyond at the proximal LEDs, and this is the another diagonal which arises, and over here you can notice at the 6 o'clock junction as well the
So you can
Wolverine
see
which
how
has
the
used.
Wolverine really does some great cuts. And I think we have really debulked this lesion pretty good. And so we are ready now to stent the vessel. And I think we're going to use a 3032 millimeter stent. So can I get a 3032 onyx stent, please? So it's 332
It's
synergy maybe.
synergy.
So this the aim of you would think that just by ballooning that you would get good lumens, but really what you get when you have calcium by doing debulking procedures, whether it be cutting balloons, Wolverine, angiosculpts, or IVL, is good lumens. In this patient, we have 180 degrees calcium, reason enough to debulk so that the stent expands well. Second issue is that we have a long lesion, and these are known to restenosis. So we need to have, and it's in the LAD, so we need to have a good outcome here. The good part is we can still see that the diagonals were patent, the LAD is good, the lumen is good, and it's time that the bed is prepared for the stenting. Can we have a picture by that time? Yeah. So you can see that the vessel is much bigger now. So can we get the 332 balloon stent, please? Yeah.
So we are using the 3 into 32 millimeter debulking stent, and as we can notice the diagonal which is still yet flowing. So let's keep it simple with a single stent strategy, and let's fix the LAD with a single stent and post dilate, and then take a call on the IVUS, which and later decide on the diagonal as well if there is any flow disturbance or patient having any EKG changes or not.
Okay, so here we go with the 332 synergy stent. The length of the lesion as uh, measured on the IVUS was 32, and we will go in with a 332. Keep a 3O balloon ready for high pressure, non-compliant ready. Small check. So that looks, it may take a cine.
I think
Yeah, I
this is
think we
a
have
good.
covered the proximal lesion and the
Correct.
distal. What do you think, Ashish?
Yes,
Should we
sir.
pull
Yeah,
that
as we
complete?
noticed that in the imaging as well, between the two diagonals, proximal, the normal segment was about 4 millimeters. So at exactly we are probably, I
A
think it has
millimeter
moved
back.
in.
Yeah.
It's moved in. The stent has moved in. So I think we are good to go to deploy the
Can we
stent over
just
here.
do a millimeter back,
One
really
millimeter
nothing?
back should do, I think.
Small check,
I
please.
think it's slightly in. Yes, I think this should do. We'll take a
Small
cine
check.
over here.
Okay, let's take a cine. Okay, that looks good. Let's go up, please. What is, no, Keep the 3 balloon
Slightly
prep,
in,
please.
yes.
So you can see that the stent has uniformly come up after the debulking with no issues. Yeah, deflate and go up once more. So with these long lesions, it's better to do a couple of dilatations of the stent so that we can get a good result. Deflate, please. Get that stent balloon out.
So distal LED averages are about 3.1. If you notice 3.15 and 3.2.
So
So
we'll just have a look what we did with the.
either we can take a 3 or 3.25, go a little high pressure distally.
That's good. Ahead. Okay, so you can see that the stent is nice and uniformly expanded. So there was a suggestion to take a 325 balloon. Okay, I think that may be good. We can do both 325 and go very high pressure in the proximal part and then check what we have to do and then use a 3.5 if required.
I think a nominal pressure with the 3 to 5 at the distal. So we're taking a 3.25 into 12 non-compliant balloon for post-dilatation. So we shall post-dilate and then take the imaging to see how the MSA has appeared.
So Rahul is asking me a question whether we should remove the wire in the proximal, in the diagonal when you're doing the proximal. You know, I don't think anything will happen, even though it's a hydrophilic wire, because yeah, we'll just take a stent boost here. Ready?
All right, so we can fluoro and then take a decision. All right, we got this. We need to go a little more.
Little bit in, yeah. Can we go off the freeze film?
Fluoro. All right. We can go
We're going to
distally.
go in a bit. Go up there. Yeah, it's okay. I'm okay. I'm pulling it back. Yeah, go ahead. So we are using the stent boost live 12, 13, 14. Deflate.
We can go a little more distally.
Yeah, I'll just do another stent boost and see. Yeah, we need
We
to
are
go in a
much,
bit, I think.
yes. Now we can just go a little distally and take a cine. Yes, I think cine now. Once ready? All right.
Okay, we still have some distance to go. Let's go ahead anyway. Here.
I think where the wire mark tip
4, 5,
starts.
6, 7, 8, 9, 10, 11, 12, 13, 14. Deflate. So we've gone up to moderate pressures here, and here we'll go at high pressure. Go to 20. This is a 3 to 5 balloon. Deflate. Go up here.
Patient is having some sort of chest discomfort. I think she should be fine with because there's a high pressure balloon.
20. थोड़ा दर्द होगा छाती में. Deflate. Go up again. 20. Deflate. 20.
So these all are being done with a high pressure with a
Deflate.
3 to 5, 12 non-compliant balloon.
Okay, now we'll quickly do an IVUS and have a look after a small angiogram just
We
to be
shall
sure
give
we have
some
not
nitroglycerine and
created
then
any
take a shot.
dissection or anything of that sort. Some nitroglycerine, please. Okay, ready for a shot? Okay,
So
looks
even
pretty good.
after the high pressure of 3 to 5 at the proximal juncture, it's yet the diagonal is still flowing. There's not much of any ECG
IVUS, please.
changes, and patient is comfortable now. So let us go with the imaging and then decide whether do we require any more high pressure dilatation at the
Okay, let's wait
proximal
5
juncture.
minutes more. We're going back with the IVUS in.
தொண்ணூறு வச்சிருக்கேன் தொண்ணூறு போயிடுமா
So this is the IVUS, which is again crossing
We're
very
distant to the
smoothly.
stent. Take some
So we are at the
pictures now.
distal segment of the IVUS and the pullback has been started. Coming to the distal segment, which is no, this is the stent portion where we can notice that not much of dissection was noted. The expansion is reasonably good. And this is all the calcified portion where the stent
இதில்
has
படிச்சுக்கிட்டு
expanded well.
மெசேஜ் வந்தால் இப்படியே ரிப்ளையும் பண்ணிக்குவேன் படிச்சுக்குவேன் அது ரெடி
And coming to the proximal segment of the LAD, over here, you can notice,
The left main.
okay, this is the left main, and which is normal. So coming to the measurements,
Let's take some measurements now quickly, and then we'll decide whether to do anything for the proximal part.
so area is about and the distal area is 7.7,
So we got a good distal area of 7.7.
7.7.
Can we have the
Probably,
minimal lesion diameter, minimal stented diameter, sorry?
yeah,
Yeah, maybe that's the place where we have the minimum stent. That was where it was very calcified.
it is all about 7.3,
7.3,
7.5.
7.4,
Probably
7.5. And
the
the
proximal
proximal?
segment alone, just a 3.5 balloon with a nominal
Yeah.
pressure.
So we'll just do a 3.5 for the proximal because we feel it can be done a bit better. And then we are done with the whole thing. 3.5 balloon, please, shot.
Short one.
Short balloon, please. 8 or 10. Can I see the proximal IVUS again? It's not bad, you see. It's about 7.24 even now in the proximal. But I think we can get a bit better there.
It's about 7.1, 7.2.
So what we're doing now is going to, as I'm going to go ahead with that tight high pressure, you can see that there's some resistance. I pull out the diagonal wire. I don't want that to get, it's a hydrophilic wire, so we don't want to get that trapped. I've removed that. Diagonal was looking good, so I don't think we'll have trouble. And we just
8.2.
go in the proximal LAD
Only
with the
the
3.5.
proximal os
and try to
Segment
get a
should be
good
fine.
result. So, okay. So I think this case is a demonstration of how we do debulking and IVUS guided imaging for a long lesion, and how you can optimize your result by using debulking and sequential IVUS imaging so as to get the maximum lumen. So
So
here
we
we
shall
go to
use
the
a stent boost.
yeah, I'm going to use a boost again to just be sure that we're not outside the left main LAD stent. Yeah,
Hmm?
so okay, can come back a bit.
Yes, just we. I think only the proximal, because beyond the proximal segment, the area
Go
is
ahead,
good.
go up to 20. So this is just to optimize the proximal. We're going to 20, 3, 5. Yeah, so that's good.
அவங்க லைவ் எடுத்துட்டாங்க.
That's what we will finish with, and we pull that out.
மீன்ஸ் ஒர்க் பண்ண ஆரம்பிச்சிட்டாங்க.
The wire slightly.
You can pull the wire out. Let's take a shot now. Just aspirate.
Just கீழே உள்ள நல்லா இருக்கு. இந்த
There
ஜங்ஷன்ல
we go.
மட்டும்.
You can see that the result is looking very good. In fact, the proximal LED stent is bigger than the native LED ostium. The diagonal is still preserved, and that is the great part about using debulking devices. Take a perpendicular view.
இல்லை இல்லை வெயிட் வெயிட் அண்ட் ஒர்க்.
All the side branches are preserved, and that's the other good part of the synergy stent, that you can literally preserve every branch as you go in. So I'm pretty happy with this result. And Ashish, are you okay with the whole thing?
Yes, sir. So the stent expansion is good. Diagonal is flowing. There's not much of CEC changes. No patient is having any discomfort. So I think we are
Okay.
good to go.
So thank you very much for the first case, and we'll quickly go on to the other lab for showing you the second case. It was relatively a simpler case, but uh, I just wanted to show a good case of debulking versus with IVUS imaging.
கேஸ்
So
ஓவரா சார்.
thank you very much, and I thank all my sisters and techs at MMM and Ashish and Rahul for the case.
Thank you.